Good afternoon and welcome to our webinar entitled Narcolepsy, Current Understanding and Future Treatments, What Every Patient Needs to Know. My name is Janine Estrada and I will be your moderator today. Today's webinar is being presented by Narcolepsy Drug Development Corporation with support from Avdel Pharmaceuticals. Before I introduce today's speaker, I would like to cover a few housekeeping items. Today's webinar is being recorded. We will be able to share a link with you after the event. We welcome you to revisit the content yourself and share it with colleagues. We will also be presenting a second session of this webinar on Wednesday, May 1st at 11 a.m. Eastern Standard Time. The registration link may be found by visiting clinilabs.com. We also invite your comments, questions, and poll responses. Please identify the interaction panel on the right of your webinar screen. If you think of a question at any point during the presentation, please add it there and we will hold it for our Q&A portion at the end of the event. Without further ado, I would like to introduce our presenter, Dr. Gary Zammit. Dr. Zammit is the Executive Director of the Sleep Disorders Institute in New York City, the region's largest accredited sleep disorder center serving patients at its private facility in Manhattan, at the Richmond University Medical Center in Staten Island, and at the Bellevue Hospital Center. He is a board-certified sleep specialist and a fellow of the American Academy of Sleep Medicine. Dr. Zammit is involved in sleep research at Narcolepsy Drug Development Corporation, where he leads a team that is developing new drugs to treat sleep disorders, including investigational new drugs for the treatment of narcolepsy. Dr. Zammit, take it away.
Thank you very much, Janine, and thank all of you who are attending today. It's a pleasure to present this webinar session to you. The title of my presentation today is Narcolepsy, Current Understanding and Future Treatments, What Every Patient Needs to Know. There are learning objectives for today's session. People attending will gain an understanding of narcolepsy as a disorder, will learn about the symptoms of narcolepsy and its course of illness, will understand how narcolepsy is diagnosed in a clinical setting, will be able to identify currently available treatments for narcolepsy, and also will learn about clinical trials now underway to evaluate potential narcolepsy treatments for tomorrow. So, the International Classification of Sleep Disorders identifies more than 80 different sleep disorders. These disorders are grouped into major categories or classes, such as insomnia, sleep-related breathing disorders, circadian rhythm disorders, and parasomnias. And one category, disorders of hypersomnolence. And essentially what that category means is disorders of excessive sleepiness. Narcolepsy is among 8 disorders in this category. There are 2 types of narcolepsy. Type 1 narcolepsy, which is defined as narcolepsy with cataplexy, and type 2 narcolepsy, which is defined as narcolepsy without cataplexy. We're going to first focus on narcolepsy with cataplexy. Narcolepsy with cataplexy is characterized by daily periods of an irrepressible or irresistible need to sleep, or daytime lapses into sleep occurring for at least 3 months. And it's characterized by one or both of the following: cataplexy and an average sleep latency of equal to or less than 8 minutes on the multiple sleep latency test, with at least 2 sleep onset REM periods on the MSLT. Now we're going to go into detail a little bit later about what cataplexy is and what the multiple sleep latency test is, and we'll also define sleep onset REM periods. But for now, you should know that cataplexy is a sudden loss of muscle tone that is characteristic of narcolepsy, and the multiple sleep latency test is a test done in a sleep disorder center that offers multiple opportunities to sleep throughout the day, and measures how long it takes to fall asleep at each opportunity. And this test is used as part of the diagnostic workup for narcolepsy. Now, if the first bullet is questionable, or the doctors cannot clearly discern the diagnosis of narcolepsy based on the first bullet, the second bullet may apply, and that is CSF, or cerebrospinal fluid, hypocretin 1 concentrations at either 1/3 of the average, at either less than 110 pg per ml or less than 1/3 of the average values obtained by normal people using the same test. So either one of these two bullets, when combined with the first bullet, the irrepressible need to sleep lasting for at least 3 months, is diagnostic for narcolepsy. Now, we know that since narcolepsy was first identified way back in the 1870s, we've known that excessive sleepiness is a hallmark symptom of narcolepsy. People with narcolepsy experience chronic sleepiness that interferes with their daytime functioning. This sleepiness can be unmasked by monotonous situations. So doing something that's really boring, being in a boring lecture or a boring movie, those situations, they don't cause sleepiness. Being in a warm room doesn't cause sleepiness, but those situations may unmask sleepiness in people who are sleepy, including people with narcolepsy. People with narcolepsy experience sleep attacks, or the sudden irresistible urge to sleep. Now, sometimes the sleep attack may come on with a little bit of warning, so that the person who is experiencing the symptom can anticipate for some time, a few seconds or even longer, that a sleep attack is taking place. But sometimes a sleep attack will come on quite suddenly, where the person really has no warning whatsoever. So the person may be awake one moment and then fast asleep the next. People with narcolepsy experience lapses in vigilance or attention. And these can be really significant because the person may appear outwardly awake to others, but internally, that person is truly detached from his or her environment, not really connected at all. So somebody with narcolepsy may really not be following what's going on in the environment around her or him. So, finally, excessive sleepiness can also be characterized by automatic behavior. And this is really acting without conscious control. It's like being half awake and half asleep, and both of these worlds kind of colliding at the same time. So people who experience automatic behavior, they may do something. There are stories of people in their kitchen putting their dishes in the clothes washer and putting their clothes in the dishwasher. Or more recently, I spoke to a person with narcolepsy who was in some important meetings at his place of work. And he was experiencing automatic behavior while he was taking notes. So he was taking perfect notes until the automatic behavior kicked in and the note taking continued, but the notes were all over the page and they were incomprehensible gibberish when he looked at them later. And that's just another example of automatic behavior. So we have a short video to show you of what a person with narcolepsy might experience. And I'm going to see if I can pull it up, if you'll bear with me for just one moment. Here we go. Okay, so let's see if I can get us back. Here we are. Get us back to the presentation. So here you can see what a person with narcolepsy is reporting, how sleepiness is such a prominent experience for her in her day-to-day life, a chronic sleepiness with multiple periods of sleepiness during the day. And this person also experiences cataplexy. So let's talk about what cataplexy is. Cataplexy is a brief loss of muscle tone. It can take place for maybe a minute or two. Sometimes the episodes can last a little bit longer. And these attacks, these cataplectic attacks, can vary in intensity. They can be as slight as a head droop, as you saw in the video we showed just now, or they can be so pronounced and so exaggerated that the sufferer will experience a complete loss of tone of skeletal muscle and collapse down onto the ground. Usually, episodes of cataplexy affect both sides of the person's body, and they're brought on by strong emotions, usually positive emotions. So emotions that might give rise to or that might be associated with laughter are the kinds of emotions that are most likely to produce a cataplectic attack in somebody with narcolepsy who experiences these attacks. And the attack is quite likely to come on suddenly and build up over several seconds. Now, I don't have a video of severe cataplexy to show you, or at least not a video in human beings, but I do have a short video to show you of a cataplectic attack in a canine. And so let's take a look at that. Okay, so you saw in that short video what a severe cataplectic attack might look like, with the sudden loss of tone of all skeletal muscle. Chloe was obviously she was quite happy going after her ball, a positive emotion for her. A cataplectic attack came on and she was unable to move. She was trying, you could tell, and her owner was encouraging her, but she couldn't get up. and then in one fraction of a second, she was able to come out of that. Cataplexy is interesting because many sleep doctors hear about cataplexy, but not everyone witnesses it firsthand, because these things often happen when people are at home or when they're engaging with family and friends. And it's quite remarkable when it happens in a human being, because you can see just how unpredictable, how sudden, and how impactful a cataplectic attack can be. Now, people with cataplexy may have as few as one event every month or two. So the cataplectic attacks may be troubling, but they may not be that frequent. But other people can experience more frequent attacks, 8, 10, 15, even 20 attacks per day. So you can see how cataplexy, on top of the hallmark symptom of narcolepsy, excessive sleepiness, can be impairing. That's not all people with narcolepsy have to deal with. There are associated features of type 1 narcolepsy, including disturbed nighttime sleep. This means that people with narcolepsy will experience frequent shifts of their sleep from deeper stages to lighter stages. There is more of the lighter stage 1 sleep. That's the type of sleep that we all have when we're first falling asleep, and deeper sleep. So there is more of evidence of a sleep fragmentation in narcolepsy, and difficulty for the person with narcolepsy to get a good solid night of deep and restful sleep. People with narcolepsy also experience something called hypnagogic hallucinations. And these are hallucinations that occur typically just on falling asleep. Sometimes a similar type of hallucination may occur just on waking up. They're called hypnopompic hallucinations. But these hallucinations oftentimes are visual, more often than anything else, and the person may see something in their environment. It could be something that is not very threatening to them, but sometimes, and very often, they experience a hallucination that causes them to be fearful. So maybe somebody in their room, somebody that they don't know, somebody standing in the doorway. So you can imagine what a strange experience that may be. The other associated feature of narcolepsy is sleep paralysis. And in sleep paralysis, the person with narcolepsy is really unable to move skeletal muscle. We just saw Chloe lose control of her skeletal muscle and fall down to the ground. Well, in sleep paralysis, the person doesn't have skeletal muscle control. And of course, there are 3 types of muscle in the human body. There's cardiac muscle, smooth muscle, and skeletal muscle. Well, cardiac muscle continues to function. Smooth muscle, like your diaphragm and breathing accessory muscles, they continue to work. But skeletal muscle, the person can't move. So usually an episode of sleep paralysis may last for just a few minutes. But sometimes sleep paralysis and hypnagogic hallucinations will occur in tandem. They will co-occur. And you can imagine if somebody is having a fearful experience with a hallucination and unable to move, how frightening that can really, really be. The good news about both of these things is that they spontaneously resolve within just a few minutes. Some people with narcolepsy have described being able to move their eyes during events, and when they move their eyes, if they move their eyes vigorously, it may kind of stimulate activity, and it helps to make their episode shorter. That's just an anecdotal description. One interesting piece about this is that narcolepsy has often been considered or called a disorder of REM sleep, or rapid eye movement sleep, because when we experience rapid eye movement sleep, there is a decrease in skeletal muscle tone. And we experience those visual experiences that are like hallucinations that we call dreams. And so it was thought very early on that the narcolepsy syndrome was in some way associated with REM sleep. And in fact, the hallucinations that people experience in narcolepsy, they're primarily visual, just like dreams. So so there was some association here between cataplexy, hypnagogic hallucinations, and sleep paralysis. And what we'll see when we get to talk about the MSLT is that people with narcolepsy have something else, and that is rapid eye movement sleep onset at the very beginning of their sleep period. So when they first fall asleep, within just a few minutes, or sometimes right at the beginning, they will have a REM sleep. That's very different from a normal healthy sleeper who will fall asleep going to stage 1, 2, 3, and then after a period on average of about 90 minutes will have their first REM sleep episode. In people with narcolepsy, there is a pressure to go right into REM sleep. So again, there are these thoughts that narcolepsy is kind of a REM sleep disorder. People with REM sleep, or people with narcolepsy, also are very often likely to have trouble controlling their weight. They gain weight, and they are at greater risk for obesity, and consequently greater risk for sleep-related breathing disorders like sleep apnea. So there can be the co-occurrence of narcolepsy and sleep apnea in people who suffer from narcolepsy. Depression and anxiety is common, and functional impairment during the day is also a common report of patients. As you can imagine, the person with narcolepsy is excessively sleepy, may be limited in their functioning because of both sleepiness and cataplexy in type 1 narcolepsy, and also may have some mood symptoms that could be disruptive to functioning as well. So let's take a look at one more video. Just have one more. Okay, so so that was Tanya, and you could hear about some of the challenges that she faced dealing with her narcolepsy in an occupational setting. It can be very challenging. let's talk about the prevalence of narcolepsy. Narcolepsy is seen in somewhere between 0.02% and 0.18% of the population in the United States and Western Europe. That's really just a fraction of a percentage, and that is why narcolepsy is often considered a rare disorder, because it affects such a small number of people. Narcolepsy affects both males and females. Males are slightly more likely to report or to be diagnosed with narcolepsy than females. If we look at familial patterns and some of the genetic work that has been done in narcolepsy, we can see that there's a 10 to 40-fold increase in the risk of narcolepsy in first-degree family members. If we look at genetic studies, there is one marker, the DQB10602 marker, and we know that that marker is increased in people with narcolepsy. About 93% of people with narcolepsy have that marker, but it's definitive because it's also seen in about 17% of control subjects, healthy people, or people without narcolepsy. So it's not a perfect match, and that's really led many researchers to conclude that while we've gained a lot of information about the genetic contributions or components of narcolepsy, much more work needs to be done to fully understand the genetics of this disorder. One thing that we do know is that the hypocretin level below 110 pg per ml is diagnostic for narcolepsy. So, that is a marker, and when we go back to the first slide that I showed you, if you cannot document narcolepsy with cataplexy and a multiple sleep latency test that shows a short latency to sleep onset, with sleep onset REM periods, which you would need at least 2 of, you can have a level drawn for hypocretin 1, and that is diagnostic. Okay, let's go to the next slide. Okay, so the onset and course of illness of narcolepsy. Symptoms usually begin after 5 years of age. Symptoms typically onset between the ages of 10 and 25. There seems to be a peak in the onset of symptoms in late adolescence, in 15 to 18, 19-year-olds, and then another peak in the mid-30s. Sleepiness is usually the first symptom, and that is often followed by cataplexy in narcolepsy type 1 within 1 year. Disturbed nighttime sleep, hypnagogic hallucinations, sleep paralysis often are trailing symptoms. So, the course of illness is quite interesting because it shows its signs early in adult life, or in adolescence and early in adult life. Okay, so how do we diagnose narcolepsy? Well, the first assessment that we do, well, if I'll step back from here, the first assessment is really work in the clinic. It's really meeting your doctor or a sleep specialist and having that consultation that would involve a thorough sleep history, medical history, and very often an understanding of any other diseases or illnesses that you may have, concurrent medications or concomitant medications that you may be taking, and then working up a diagnosis first in an office setting. It's quite likely that if the physician suspects narcolepsy, that the patient would be referred into the sleep lab for polysomnography. Polysomnography is an all-night sleep test in a sleep laboratory environment where brain electrical activity and other measures are obtained in order to evaluate nighttime sleep and also evaluate sleep latency. How long does it take to fall asleep at night, and how long does it take to go into rapid eye movement or REM sleep? Sometimes even at night, people with narcolepsy will go into a period of REM sleep very early after they get into bed. Multiple sleep latency test. This, again, is a test that gives the patient multiple opportunities to sleep during the day in a darkened room, typically wearing street clothes and laying on a bed. And we can assess how long it takes that person to fall asleep. People with narcolepsy, if you look over to the right, the graphic, people with narcolepsy take just a few minutes really to fall asleep under those test conditions. These tests were done around 9:30 in the morning to start, 11:30, 1:30, 3:30, and then 5:30. So there was a series of 5 tests done in this particular study that was completed several years ago. But you can see that the person with narcolepsy is falling asleep in just a few minutes, whereas a normal, healthy person, represented by the upper line, is taking somewhere between 9 and 13 minutes to fall asleep under those conditions, sleep favorable conditions. So there's clearly separation between the degree of sleepiness that somebody with narcolepsy experiences and a normal healthy sleeper. And then finally, we look for sleep onset REM periods. So going into that rapid eye movement sleep at the onset of a sleep period. And the MSLT offers us 5 opportunities to assess that. For narcolepsy, you must have 2 or more sleep onset REM periods to be diagnostic of narcolepsy. If you only have 1 during the MSLT and you have had 1 at night when you did your polysomnography, that would count. So that's how we diagnose. And if there is any type of misinformation or unclear information, not misinformation, unclear information on the polysomnogram or on the MSLT, and a definitive diagnosis can't be made, then you're able to collect the CSF hypocretin 1 level to determine if the patient meets diagnostic criteria for narcolepsy. And as I said, levels below 110 are diagnostic for narcolepsy. One of the unfortunate things about narcolepsy is that many people will go for years without getting an accurate diagnosis. Sometimes they're not brought to the attention of a healthcare provider. Other times, healthcare provider may not recognize these symptoms as symptoms of narcolepsy very early on. So some people can take years to find a practitioner who will conduct the assessments to make an accurate diagnosis. Now, the type 2 narcolepsy. Remember, we said there were 2 types, type 1 and type 2. Type 2 narcolepsy is narcolepsy without cataplexy. So cataplexy is absent, and excessive sleepiness on the MSLT is not better explained by other causes. So there are multiple other conditions that result in hypersomnolence. Remember, I said that narcolepsy is one of 8 conditions that are in that category. So there are categories or disorders such as insufficient sleep, not getting adequate sleep, or sleep apnea, a sleep-related breathing disorder that can give rise to excessive sleepiness during the day. But if not better explained by those other causes, and without cataplexy, type 1 narcolepsy may be diagnosed. The prevalence of type 2 narcolepsy is not very well known, not as much as type 1 narcolepsy, because its symptom picture is a little bit different, but it's believed that it represents between 15 and 25% of all people with narcolepsy. Cataplexy may develop later in the course of illness, so someone may be diagnosed with type 2 narcolepsy early in life, but then cataplexy symptoms may start to occur. And in that case, the diagnosis or narcolepsy type would be modified in terms of the diagnosis. Now, in all cases, when the diagnosis of narcolepsy is being made, the sleep specialist or practitioner is going to do the work to differentiate narcolepsy from other types of disorders associated with excessive somnolence. So, so if there is a concern, a question mark about whether a diagnosis is type 1 or type 2 narcolepsy, well, the CSF hypocretin 1 sample may be obtained because we know that that is definitive for type 1. Idiopathic hypersomnia is a disorder that may be diagnosed when there is no cataplexy and no sleep onset REM periods on the MSLT. People with idiopathic hypersomnia, though, are different from the typical person with narcolepsy in that they are usually long sleepers. They have very long periods of sleep during the night, sometimes stretching out into the morning, and they often take long, unrefreshing naps, as opposed to people with narcolepsy, whose naps can be quite refreshing. So, so idiopathic hypersomnia is another differential diagnosis. And then finally, insufficient sleep, which simply means not getting enough sleep, sustain wakefulness satisfactorily throughout the day. So, so the diagnostic workup is going to include consideration of all of these. Now, let's talk about treatment of narcolepsy and what happens once narcolepsy is diagnosed. Well, there are several drug treatments or pharmacologic treatments that are available for the treatment of narcolepsy. This includes drugs like modafinil or armodafinil, known as Provigil and Nuvigil. Both of those are designed to treat excessive sleepiness. They promote wakefulness. They're actually the same drug, but different formulations. So modafinil is a formulation that can be given once or sometimes more, but once during the day. Armodafinil has an extended duration of action, so the effects will last longer throughout the day. But the goal in treating narcolepsy is not only just to treat the excessive sleepiness, it's really to treat the patient, to treat the full set of symptoms. And in type 1 narcolepsy, we know that cataplexy is a prominent symptom, no matter how frequently it occurs. But especially when it's occurring frequently, cataplexy needs to be addressed. Well, that may be addressed with sodium oxybate, or a medicine known by the trade name of Xyrem. Sodium oxybate is actually known to effectively treat both cataplexy and excessive sleepiness. So that's a treatment option. Alternative treatments are available for many years. Amphetamines or amphetamine-like drugs have been used to promote wakefulness, and in addition, tricyclic antidepressants and the serotonin specific reuptake inhibitors have also shown to treat the associated symptoms of narcolepsy, including sleep paralysis and hypnagogic hallucinations. we have more recently added a couple of newer treatments. One is solriamfetol, or Sunosi, which was recently approved in the United States for marketing, and that is norepinephrine dopamine reuptake inhibitor that is known to promote wakefulness. That's a wakefulness promoting drug. And then pitolisant, which is approved in Europe, not yet approved in the United States, but there is an application under evaluation now, I believe, to determine whether or not pitolisant will be approved in the US. It was granted breakthrough therapy status by the FDA. And there are other drugs in development for narcolepsy, and here this is not a comprehensive list, but they are here. One is FT218, which is a once nightly formulation of sodium oxybate. So currently, sodium oxybate is taken in 2 divided doses because of its duration of action. So the person will take a dose of medicine at bedtime, and then a few hours later, will take a second dose in order to promote sleep during the second part of the night. The FT218 drug is a once nightly formulation. So that's a medicine that would be taken at bedtime if it were approved. THN 1,2 is a modafinil flecainide combination, and that is a combination of medicines that that involve both the traditional modafinil as well as a second drug that has been used to treat cardiac arrhythmias. AXS-12, or reboxetine, is a highly selective norepinephrine reuptake inhibitor, also under evaluation as a wakefulness promoting drug. And JZP-258, a low sodium formulation of sodium oxybate, with preliminary trials showing efficacy compared to placebo. And there are drugs that act on the orexin or hypocretin system that also have been examined. So there are several medicines that are in development for the treatment of narcolepsy, and that if the clinical trials proceed and are successful, may be under consideration for approval. Behavioral treatments for narcolepsy also are available. Getting adequate nighttime sleep, making sure that enough time is set aside for sleep, scheduling daytime naps. Sometimes just 1 or 2 scheduled naps during the day, even short naps, 15 minutes or so, will have a significant impact on a person with narcolepsy. Eating a good diet, getting good exercise, and even talking therapy can sometimes help to manage the day-to-day experiences that people with narcolepsy can have. As you can imagine, as young people begin to experience symptoms, they may have concerns about socializing, about performing in academic settings or in work settings. So having someone to talk with and understand what's going on can be very helpful. And then certainly avoiding sleepiness-related risks is also a part of how behavioral treatments for narcolepsy can apply. And as you heard in one of the videos, I believe the first video, the patient said that she would avoid going swimming because she understood now that this represented a risk for her. She could have an episode of cataplexy while swimming and not be able to recover. So avoiding those risks also becomes part of kind of a treatment or day-to-day management program. Now, there are many trials that are currently enrolling for narcolepsy studies. These are a few of them. One is the CONCERT study. That's the first bullet. THN 102, JZP 258. and then sodium oxybate for the treatment of excessive daytime sleepiness and cataplexy in narcolepsy. For those of you who are interested in any of these trials, I'm going to put up a resource slide in just a moment. But for the final trial, the REST-ON trial, subjects have to be at least 16 years old. They have to be diagnosed with type 1 narcolepsy or narcolepsy with cataplexy. And they have had to never had Xyrem or sodium oxybate before. That particular trial is about 13 weeks in duration of the treatment period with a screening period that precedes it. If you would like to get more information about narcolepsy or about clinical trials, here is where you may go. To identify sleep specialists in your area, board-certified sleep specialists, you can go to the American Academy of Sleep Medicine at aasm.org. To identify a patient support group and meetings that may be in your geographic area, you can go to the narcolepsynetwork.org. For clinical trials in the Northeast region, or some of them anyway, you can go to clinilabs.com. For a comprehensive list of clinical trials currently underway in all regions of the United States, you can go to clinicaltrials.gov. And finally, if you are interested in the REST-ON trial, the last study that I just described, you can visit the website restontrial.com. So with that, I will close, and I thank you for your attention, and I'm happy to stay on board for any questions that you may have.
Just a friendly reminder, if you'd like to ask a question that maybe has not yet been submitted, so a panel on the right, it's labeled questions at the top.
Okay, we have our first question. The first question is, I'm chronically sleepy. How can I tell if it's due to narcolepsy? Well, it's a good question. Remember that there are many different disorders that can result in excessive daytime sleepiness. Those range from insufficient sleep to sleep apnea to narcolepsy and to others. The best way to evaluate whether or not your sleepiness is related to narcolepsy is to talk to your doctor and follow your doctor's guidance with regard to a referral to a board-certified sleep specialist who can evaluate your symptoms in the office and then in a laboratory environment with polysomnography and the multiple sleep latency test. It's really following through all those steps that let you define and categorize your symptoms. And let's see, and there was one question just popped up. I missed the webinar. Can we access it again? And the answer is yes, of course. And you can access it by going to www.clinilabs.com. I have another question. Every now and then I experience something like sleep paralysis. Is that a sign that I have underlying narcolepsy or that I'm at risk for developing narcolepsy? And the answer is sleep paralysis can occur completely independently of narcolepsy. So just because you've had that one symptom, it doesn't mean that you have narcolepsy or that you are in fact at risk. Sleep paralysis is part of the narcolepsy tetrad or group of 5 symptoms, hallmark symptoms that comprise it, but it's not a hallmark. It's not like cataplexy. So you may have sleep paralysis all by itself, and it doesn't necessarily mean that you are at risk for developing narcolepsy. Okay, and I think our last question is why join a narcolepsy trial when I could get a prescription medication from my doctor? Well, that's a good question. There are multiple reasons for joining a clinical trial. It may be that you are particularly interested in contributing to new medications or to the development of new medications that might help people with narcolepsy in the future. The clinical trial procedures that are involved, they tend to be performed by very good clinicians at reputable centers, and um, and you'll have the experience of working with a skilled investigator and team of healthcare professionals that would be supporting you during the trial. Some people are quite interested in that. And there are both benefits and drawbacks to a clinical trial. So it's worth looking at the clinical trial opportunity and assessing it to determine if it's right for you. Sometimes the trials can be both very informative, not only to the doctors who are running the trial, but to the patients who are participating. Okay, I think those are all the questions. So with that, I will thank you again for your participation, and we appreciate you taking the time out of your day to participate in this webinar. Thank you.